This is It's Not In Your Head podcast with Dan and Juz. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers.
Hello and welcome to episode 12 of It's Not In Your Head with Dan Bates and Justine Fidelson.
Hi, Dan. Way to say my name perfectly.
I know. I've realized I have to say it with an American accent. And if I say Fidelson, yeah, then I get across the line. I've struggled for the last 10 months to get your name correct. So
everybody says it wrong. It's totally fine. But yeah, here we are.
Okay, so today what we're going through is we're going to go through a little bit of a recap of what we've talked about over the last couple of weeks and then answer one of the questions that we've had, which is, okay, what do we say? So as a recap, just because a patient doesn't respond to therapy or doesn't respond to treatment doesn't mean it's in their head. Similarly, if you can't diagnose it, doesn't mean it's in their head.
Right.
And importantly, it comes with a harm. This is a group of patients that have a 25% risk of suicidal ideation in the last 2 weeks. So telling patients that the pain is in their head, it increases their risk of hopelessness. It increases their risk of suicidal ideation by up to 500 to 1200%.
Yeah, it's massive.
Another analogy to think about it is that if you have a patient that has the risk of liver failure, and I, as a doctor, give that patient a drug that will possibly increase the risk of them having liver failure, and they go on to have liver failure, and heaven forbid they go on to die, that's actually my responsibility. And I need to come up with other solutions for their problems and for how to treat them that doesn't involve that medication that increases the risk of liver failure. We need to do the same for how we educate and treat our patients with chronic pain.
Right. So we basically got a lot of good feedback from the last episode where clinicians are now hearing and understanding that the way that pain is communicated can be harmful to patients. And the challenge, though, that introduces then is, well, what do we say instead? And this whole topic is so interesting to me because there is so much value in pain science and pain education and understanding what is happening to your body and being able to differentiate rather between what do you impact and how can you downregulate, desensitize, distract, right? Manage the output of pain, manage your mindset and your perspective and that sort of automatic, stress response that gets reinforced and reiterated when you've lived in pain a long time. There is a ton of important aspects of that are frankly non-negotiable the more pain you end up in and the longer you've had it. But there is also a massive element of inadvertent harm that is done when pain and what is happening to patients is communicated in ways that is either intentionally or heard, in different variations of it's in my head or it's imagined or your brain is producing it. And so what we want to accomplish through this episode is help you guys better deliver a message that allows you to tease that apart for your patients without increasing suicidality. Because the truth is it's not the patients that scream at risk that have been thinking about these types of negative things necessarily in the last 2 weeks. It's your patients that you think are okay, right? It's the patients that are the status quo. It's the patients that are seemingly coping because pain comes with a lot of pre-existing and coexisting, challenges, traumas that make it difficult and predispose that population even without the element of pain is really hard to deal with. So I think being aware and sensitive to that can help a lot. And that's, what we're going to unpack on this episode is basically taking the good and then using different terminology for some of the bad or more harmful. So if Dan, you can kind of take us through how pain neuroscience at present goes through this and some of the ways in which they define how they're explaining this process to patients.
So one of the other important things that we'd like people to start doing is if a patient tells you they've been told that it's in the head, we want people to start asking, are you okay? So, and I'm going to say myself, I have never asked. I 3 or 4 times a week get told by a patient that someone else has told them their pain is in their head. And so I've never asked if they're okay. And so this week, and this patient's given me permission to use this story. This week, one of my patients who has what looks like a degenerative neurological disorder of some sort, of which part of that neurological disorder is severe colonoparesis. So to understand, that is where her colon dilates so much that she can't go to the toilet and she can't clear her colon out. And so she gets massively impacted, and she has fought it for years. And they're now, they're going to do a complete colectomy. So they're going to cut out her entire large intestine. And so she had seen a neurologist during the week who had basically said to her, you've got a functional neurological disorder. And added to that, with the quote being, we've been doing neurology for 250 years now. I don't think we're going to find much else. Okay.
Skin crawl.
Yeah.
Stomach drop. Yeah.
And so this made her exceptionally suicidal. Like, exceptionally. This is someone who has fought for years. And to have someone, essentially tell her it's in her head, very much tipped her over the
effort. It's
And so obviously I'd been thinking a lot about this stuff, and it was really the first time ever that I asked, "Are you okay?" Did that trigger off any suicidal thoughts? And she opened up and she said yes. And and she said, "Look, the only reason I didn't kill myself is because of my kids."
Right.
Right. And I
so
think
normal.
that And I just inquired whether she's safe. And yes, so she's on the other side. She's, no plans, et cetera, et cetera. But, certainly no need to have triggered that. And, in that setting, does she have a functional neurological disorder? For me, I think the answer is no. I think she has something we can't diagnose. And I think that if you apply the definition of FND, which is it doesn't fit into other known neurological disorders, she probably technically does fit the diagnosis, but that doesn't mean there's no pathology. And it doesn't mean that telling patients that it's in their head and then being somewhat condescending is in any way helpful. And it is quite the opposite. It's very dangerous.
Unhelpful. Yeah.
So now, obviously, that's not the way to do it. And there is a bunch of pain education techniques that are out there, pain neuroscience education and other versions of that have been developed over many years that have some great stuff in them that both Justine and I use all the time. Like, I grew up with pain neuroscience education being a part of as I developed into this area of medicine. And so it's kind of the way I think about pain. But as we discussed, there's stuff in it that can we remove the things that might create harm and keep all the stuff that's good. Yeah. And so what we wanted to do first is, so we don't misrepresent anything, we wanted to be able to, describe, actually, I'm going to read directly how two major groups at the moment describe their therapies. And we're then going to go through the papers just quickly, relatively quickly.
It's quickly for us.
Yeah, quickly for us. And take out all the good stuff. And just highlight maybe, there's other ways to phrase some of the more bad stuff. So paper 2015, basically on Mosley's and Butler. So it's Lorimer Mosley and David Butler's version of pain neuroscience. They describe that pain neuroscience education refers to a range of educational interventions that aim to change somebody's understanding of what pain actually is, what function it serves, and what biological processes are thought to underpin it. It refers to both a theoretical framework from which to approach pain treatment, and it also the approach itself. This approach of pain neuroscience education is not a specific set of procedures or techniques. The core objective of the approach to treatment is to shift one's conceptualization of pain from that of a marker of tissue damage or disease to that of a marker of perceived need to protect body tissue. Okay. That's all good. We're sort of pretty much on board with those things. That kind of fits in for us around techniques of filtering, techniques of rewiring, and understanding how pain actually fits together, which makes sense.
Right. It's what we're even doing on this podcast, right? What are the
Yeah.
different pieces? What can you impact? Yes.
Yeah. The other major approach at this time was published by Asher in 2021. So how they describe their model. So Asher's model provides patients with a causal model of pain as due to brain processes and not due to bodily injury. Viewing pain as a brain-generated false alarm, it emphasizes that pain is reversible and the body is healthy. This conceptual framework is similar to several pain neuroscience education protocols. Yet, previous studies have found that pain neuroscience education alone, without guided exposure, cognitive restructuring, and somatic attention and awareness, found that pain neuroscience and education alone typically has limited effects on reducing or preventing chronic pain.
And if you think about it, that makes sense, because with pain neuroscience, it's not enough to just understand what's happening to your body or to be able to tease that apart from an education perspective. You have to also be able to actually have techniques and strategies and ways to then, through action, impact your pain. And also from a perspective point of view, start to frame things up differently and look at why pain is happening, perhaps in a little bit broader, more open-minded ways, such as, yes, right, pain is overprotective. There's certainly a big aspect of pain that is not necessarily because of tissue damage and not necessarily because of structural injury. That's fair. There's also a big element of pain which can be turned up or down at the spinal cord level. That's essentially the entire amplification process that we've been talking about and teasing apart with sensitization, and all the different buckets under that you can impact with different behaviors, different medications, different things that change that process not in the brain. There's also the truth that the danger signal isn't necessarily signaling real danger. It's not necessarily a threat. And that sensitivity dial can also be turned up. These are all aspects of pain, that are important to understand. And actually, if you can be open-minded about it, empowering as a patient.
Yeah, so you can have an original injury and the signal becomes disproportionate because of changes in the nervous system.
Right. And that amplification process and those attitudes, the way you frame that and the way you approach and understand that can be done well with these different schools of thought. And when you think about some of the techniques that you're using to either desensitize, downregulate, distract yourself from pain, a lot of it centers around this concept of DIMS and SIMS, danger in me or safety in me, which is essentially an attempt at rewiring around that disproportionate signal, like Dan just touched on. And changing that, kind of automatic stress response is a bit of a learned experience that you have to be intentional about, and being mindful and aware of, even though I feel or I sense danger, is there actually danger right now? Could I maybe find ways to change the way that I'm responding to that situation? And this is one of the reasons why movement is such a powerful tool in the context of being able to change that narrative that your nervous system is rightfully so, relaying to you based upon experiences that have happened over and over again. And so if you can start to change that dialogue and change the way that you approach that process by understanding what is happening to you and then having the appropriate techniques to change that response at a spinal cord level, that's all good stuff. We like all of that. And the downside, though, is that unfortunately, in the way that these messages are communicated, you don't feel empowered as a patient. And in fact, you are left feeling hopeless a lot of the times because of the blame and shame that inadvertently comes across in the language that's used. So we'll go through some of the things that, from a verbiage perspective, could ideally be more avoided, even though the techniques are valid and helpful.
Yeah. Look, and I think that, some of the things that Asher highlights is, what they refer to as somatic tracking, reappraising pain sensations, managing stresses, amplifiers, and focusing on a positive environment and pleasant sensations. Like all that sort of stuff is good. Using humor, understanding, and using different ways to actually manage pain, manage the environment, and downregulate that disproportionate signal that has been driven by the nervous system.
Right. And these are the pieces too, right? Where from stress management, recovery, like these are the aspects that they seem kind of vague and ambiguous, but this is what it's getting at decreasing stressors, amplifiers. And a lot of that is the day-to-day routine, pre-existing, or coexisting things that pain patients deal with just by nature of being in this position a lot.
Okay, so they're the good bits. And there's lots of stuff, and we'll talk into that. And we'll very much reflect on and go into Justine's system, which is the Mars approach over, undoubtedly multiple coming episodes. If we then look at pain neuroscience and where does it potentially run into a risk of harm in the setting of increased risk of suicidality? So 2023, once again, it's a quote. So pain neuroscience is teaching people that their danger transmission system can become very sensitive. We agree, which can lead to more danger messages. True. But it is always the brain that decides whether or not to produce pain. Patient is lost. And I think, and that's the point. It's that piece there where the brain decides whether or not it produces pain. And so,
because that infers the blame and shame. You're choosing to,
and you've just told the patient it's in their head. And it doesn't matter how much you've got the explanation of peripheral sensitization and central sensitization.
What came before.
How you've explained their amplifiers, how you've worked through managing their anxiety, work on their movement. As soon as you've told them or they have heard that it's in their head, they're lost. And the reason for that being is I think that it's very difficult for people to understand that, at the level of the cerebral cortex, that you have a choice for a disproportionate signal that's coming through. And I think if everybody
how do you deploy that choice?
How do you deploy that choice? And so if you want to look at it from a purely physiological perspective, it's actually correct. Like at the end of the day, you are receiving a signal in that then gets translated into the sensation of pain, which has both, the ouchy component, and it's actually got the negative emotional component. However, if you're anywhere near a window and it's a blue sky outside, what I want you to do is I want you to look outside and see that the sky is blue. All right. And so what is taking place there is that there is a set of wavelengths at about 480 to 500 nanometers that are coming in. They are hitting your retina. They trigger off a set of cones that respond to those wavelengths. That then triggers off a signal that goes to the visual cortex. And in the same words, your brain then chooses to see the sky as blue, which is technically physiologically correct, but it's really hard to swallow. Like, I can't look outside and go, the sky's blue because my brain decides it's blue. And I think that is the problem with explaining pain as you have pain because your brain decides the signal is painful. It's just where it is probably technically correct, it's just not helpful. Yeah.
Well, it's not actionable, long stretch. Right? Because you can't do any alternative. Just because you also choose to see the sky as blue, you can't then decide to see it as green or as some other color. And we'll actually, should we show them the little diagram?
Yeah, so we can put up the diagram.
You can actually see then on this new and improved pain skill over here. So here you can see we have a 10-point pain scale, two of them technically, one with a white background, the other with a bright green background. The faces themselves go from very light blue on the left, where your pain score is a 1 to 2, then a 3 to 4, then a 5 to 6, then a 7 to 8, then a 9 to 10, going from lightest blue on the left all the way over to darkest blue on the right. And what's really interesting about this is with the two different background colors, one being white, one the neon green, you can actually see that the blues further to the left are a slightly different hue, especially compared to the darker blues all the way over on the right. And so what this shows is really an example of how if you change the context, you can change the pain, or the patient rather experiences a different level or amount of pain. And the color is not the only thing that changes. If you look really closely, it's actually also the sharpness of the edges. So on the light blue all the way on the left, when it has the bright green background, it's much harder to make out the outside. And so this is what speaks to, even though, people's diagnoses may be similar or the same, given different contexts, given different pre-existing histories, coexisting stuff, various things that amplify and change their experience of pain. That then changes the output. And the darker, the muddier, the more intense the pain gets, the harder, though, it is to change. So the dark blues all the way over on the right maintain their vibrant, dark contrast compared to the lighter blues on the left. And the other thing, that I think is important to take from this too, is that certain therapies, and some of the ones that we're even talking about, are more effective for the 3 and 4 level of pain than the 9 and 10 out of pain. The 9 and 10 out of pain is really hard to change or to bring down 50% with mindfulness or distracting or whatever. But a 3 out of 4, you can really impact that with recovery. You can really impact that with certain things. And it's not that you can't impact more intense pain with those same strategies, but it's a smaller piece of the pie, right? It's a smaller proportion of the output. And so to expect everyone to be able to also impact their pain the same or be able to change the color isn't really fair or realistic. And I think if you can use this example to kind of put that in perspective, it can help you see how lower amounts of pain will respond better to therapy than higher amounts of pain. And it's not the patient's fault that happens.
Yeah. And one of the things I think is important about this as well is there was a paper published by Dirk de Ridder a number of years ago. And even though, at the lower ends, it's probably easier to change with these sort of techniques, at the higher ends, what they were able to show within this paper is that patients with pain in the area of below 5, basically, it was this paper. Right. They showed that patients cope relatively well. In 5 to 6, they had an increase in suffering. And then at 7 and above, they had increased levels of disability. Okay. Yeah. And so one of the things that becomes important that even though it's hard to shift the degree of pain, these techniques may bring the patient's pain down enough that you take them from a 7 or 8 and down to a 6. And so what you've done there, you've taken out a degree of disability, although you may not have taken out a ton of pain. And then the next step down, you take out a component of their suffering.
I love this. Yeah, this is hugely important. Yeah.
But it's actually really hard to change the degree of pain. And so...
Yes, so good. Because I talk about all the time how pain and suffering are different.
Yeah. For me, this is about realistic expectations setting. Being in a setting where you've got moderate to low levels of pain, you're in the 2 to 4s type range, even though it can be highly intrusive, it's still, these techniques can shift that pain quite significantly.
How much it impacts you and how much of a center of your life it is, right? Is it this humming thing in the background or is it a constant focus?
But high levels of pain, being able to shift them by 2 points, you're probably going to take out a degree of disability. You're probably, you can take out a degree of suffering. And those points, really important. So the point I'm trying to make here is just because, we're indicating that at the bottom end, you can decrease pain significantly, maybe to 0 if, if you believe some of these papers. But at the other end, it's not going to take it to 0. But it is going to take away some of the disability, some of the dysfunction, which is really important.
And I think what I really want to highlight too for patients in that bucket, because those are the patients I work with, and this is my whole work, is helping 9 out of 10 pain patients with these types of techniques that they impact, that they can integrate, that they can gain mastery over. And they go from, I want to kill myself, right? I cannot imagine the rest of my life like this, to I can do business with this. I am not in no pain, right? I'm still in 6, 7s, right? There is still a ton of progress to make. But if you can get out of the SOS danger zone and not increase harm, but bring people down, then you give them hope, right? The opposite of helplessness or hopelessness is hope. So I think that's a really important message to take from it, is that it's not useless for really high pain. It's just a different proportion of how it's going to impact you.
Yeah. As you're explaining these techniques, there's probably a couple of words that seem to be heard as it's in your head, rather like more so than other words. So I think using the word brain very much highlights it's in your head. Think, decide, perceive, interpret, misinterpret. All those words, when you're on the patient side, get heard as it's in your head. And I think that on the clinician side, we don't feel we're telling patients that it's in their head. We're telling them it's a misinterpretation. But what it's
Right.
getting heard as is, well, I just think this is all in your head.
Right.
And there's a couple of phrases from the supplement from the Asher paper from 2021 that, we feel may be heard as the pains in your head. So I'll just sort of read
Yeah.
through three of them. The first one is, like, your brain is simply misinterpreting the signals coming from your body as if they are dangerous. Okay. Once again, I can personally see how you're being told that's in your head. Next quote from the same supplement of that paper is, but there's nothing wrong with your back. Your muscles, your tendons, your ligaments are all perfectly healthy.
It's quite an
Okay.
assumption.
We're going to step down into that in a moment, because I think that a lot of the time that's hard for people to buy when they've seen scans, they've read reports, and then you're just telling them it's
No.
perfectly healthy. And then, the last piece being, we know there's nothing wrong with your body. This is your brain putting on a show for you. It's just interesting, burning sensation, but we know that it's safe. Just sit back and enjoy the show.
Oh my God. That's not going to go over great with any.
Okay.
So imagine someone in extreme suffering, right? How is that going to land?
Yeah. And I think it's that, like,
it's kind of condescending and it's hard to digest.
Yeah. And I think that the one thing, this paper's got some good techniques, is semantic tracking, et cetera, et cetera, et cetera. But I think that phraseology along those lines, for me, increases the risk of harm to the patient. And that I don't believe is acceptable, no matter how good the outcome for the patient. And one of the things I think that happens as well is that, patients feel they're being lied to. So one of the quotes out of the same paper is, your back is perfectly fine. Okay. So interestingly, in the same paper, they reported 20 MRIs out of 150. So we're missing 130. Out of those 20, 15 had disc degeneration, 7 had disc herniations or ruptures, 14 had spinal malalignment, 13 had osteoarthritic changes, 9 had neuroforaminal narrowing. So that's a decrease in the space that the nerve moves out of, and 9 had central canal stenosis. And so that's where you get a complete decrease in the entire circumference of the spinal canal. And so
there isn't nothing.
So, yeah, and I think that's the problem. So if we're using quotes to say to our patients, your back is perfectly fine, I think patients are not stupid. They read reports from scans, and even if they don't understand, all the Latin words that are in there,
right,
they understand the word severe, and they understand the words degeneration. And they understand the words osteoarthritis. And so I think that, going that direction, you're starting to lose trust.
You lose trust.
With the patients.
Right. And you could do it without that.
Scans do it. And how do you get around it? And so, like, the way I deal with scans, because most of the time, for example, a lot of people will come in and say, my back pain is due to my L4-5 disc degeneration. Okay. And so it is very common to have L5 disc degeneration. And when you go and actually look at the literature, disc degeneration does not match very well with the presence of pain. Okay. However, the way I then explain it is, that's where I start. All right, so yes, you've got disc degeneration. However, it doesn't match very closely with the presence of pain. So you've got multiple discs throughout your spine. You've got even some that are up a little bit higher where you don't have pain that are degenerated, okay? What does match with pain on scans is the presence of what's known as an annular tear or a high intensity zone, the presence of modic changes, which is essentially inflammation in the bone on either side of the disc that shows there's been some disc degeneration that's been there for a long time. And the third piece is what's called a disc extrusion, which is where you've squeezed the jam out of the disc. So the jam, the jelly. So the ways to think about a disc is, it's like a jam or jelly donuts. So jam if you're in Australia. So when you have a disc bulge, it's basically like just squashing the donut and it just gets fatter. If you have a disc protrusion, it's like getting an outpouching of the dough itself. And when you squeeze the jelly out or the jam, that is a disc extrusion. If you have the jelly breaks off, it's a disc sequestration. So that's how you think about those things. And so being able to explain what the finding is on the scan takes out the fear.
Right.
Hey, yes, you've got some disc degeneration. It doesn't normally match with pain. You don't have the three main things that do. You don't have high intensity zones or annular tears. You do not have modic changes. You do not have disc extrusions.
Right. And then patients can understand, instead of feeling lied to, not given an investigation that they feel would help them, right? Because the other challenge with telling patients or a version of pain is in their head is the reason patients are looking for a cause is because you can treat that. When you point the finger back at the patient, and it's not that you can always find a cause, and it's not that the patient has no responsibility, but when you point the finger back at the patient, there's not a lot that they can then do with that, especially if they aren't given further tools and direction.
Yeah. And explaining the findings is not the same as saying your back is perfectly fine, which the patient doesn't buy because they read the scan.
That's not true. Whereas what Dan just said is true, right? So you still have the same interaction without the harm. And that's the goal.
All right. So there's multiple ways to go around it.
So instead of the misinterpretation brain bit, basically, similarly as with the pain puzzle and other aspects of this whole podcast, where we're trying to get patients and physicians to look at the different aspects in a way of pain that they can treat more effectively. And if you can't tease those apart, it's difficult to. So similarly in this setting, instead of misinterpretation and brain, it's this 4-part series where first you have to find and fix what are the potential causes, what are the drivers, what are the various inputs. They could be injuries, they could be peripheral sensitization, they could be link tension relationship, inhibition type of stuff. There's, they're not all necessarily intervention fixes, but this is the piece where you do need a good interventionist. This is I need a good pain doctor. I need someone that I have a collaborative, positive relationship with, where you can hunt those pieces of it down, that I cannot mindfulness myself out of certain drivers to my pain, right? I got to do my piece. The physician has to do their piece. So that is number one, so that you're not trying to fix a house with things that are unaddressed as far as cracks in the foundation, because that's what leaves the patient in a difficult position if they can only get so far. Obviously, there's natural and inherent, diagnostic and therapeutic limitations, but we want to do the best we can with step one. Step two, this one's more on the patient, filtering. So find and fix, then filter. You want to be able to, like we've talked about before, downregulate, desensitize, distract. I use like the 3D model with my patients to make it easy to remember. So downregulating, diaphragmatic breathing is a really good example of that. Making your environment more soothing, various ways to manage anxiety, distraction techniques, music, podcasts, social. TV is not a great one, ironically, because it's pretty passive. So it's hard to actually get your mind off of pain with that. More engaging things typically help, but there's a million different things that you can do to distract. And then from a desensitization perspective, that's kind of also, it depends on your diagnoses and how you'd want to do that. But those are ways that you can utilize a lot of different techniques in the management department, right? So with symptoms of chronic pain, that's why it's hard. On one hand, yes, you want to cure what's causing it, but if you can't, you have to really impact and improve how you manage it. And ideally, you're doing both sides of that. And these are examples of that are in someone's wind down routine, in someone's sleep and recovery piece of the day. How are you able to be productive? Even me, like doing the podcast, you see me squirm, you see me do kind of weird stuff to manage my own ability to be on task. The third part is also kind of patient heavy, but this too is a patient physician collaborative effort as far as turn down the amplifiers, right? So some of that you got to outsource. We talked in earlier episodes around various medications that Dan can help with that help some of the sensitizations, and especially if you have underlying, neuropathic pain, or how can you kill two birds with one stone if depression is a major coexisting challenge, if sleep is the major coexisting challenge. So being able to improve those buckets of, right, fatigue, extreme sleep disturbance, mood issues, motor dysfunction, various dysautonomias. Those are all big pieces of how you can decrease your overall output. That is all of the MARS stuff, right? Movement, awareness, recovery, stress.
Under that bucket for me goes as well is metabolic abnormalities. And that's
one.
really where, your doctor can be part of not just trying to, diagnose where the original thing is, but actually look at what other metabolic abnormalities have you got going on underneath this. We
Yeah.
know that just looking at the literature, the things that really amplify pain are inflammatory disorders. Maybe there's an underlying inflammatory disorder.
Right. This is
The
that
next
coexisting
thing,
piece. Yeah.
absolutely. The next piece that's most associated with that is pre-existing depression and anxiety. This isn't the anxiety or depression that comes
Right.
after you develop
From.
your pain, which
Right.
does amplify it, but it's the
Right.
pre-existing stuff because other stuff's going on. So in
Yeah.
that setting, yes, identify its problem and go on and use your psychologist and
Right.
use your psychiatrist and use your medication to get on top of that, get on the top of
Yeah.
that stuff. And the third piece, which we will dive into probably in significant detail further down the track, is hypermobility. Hypermobility is linked with central sensitization extensively. And there's probably ways we can go about dealing with that. And so, yes, turning down your amplifiers is really important and identifying what they actually are. And that's not just done by you, that's done by you and the team around you that supports you.
Right. And some of those pieces are outsourced. And this is also a find and fix. I mean, we're talking about it in relation to causes with pain with number one, but you want to do the same thing with your amplifiers. You have to identify them to actually treat them. And sometimes it's the patient, sometimes it's the doctor who has got to help fill in some of those pieces. And then last piece of that, rewire. This is kind of my favorite because obviously I'm a movement professional besides a pain coach, and movement for me is such a powerful tool to help patients be able to change their experience with pain and start to be able to have new experiences that are more confidence inducing rather than reinforcing that, again, valid stress and fear response until you're able to kind of change the way that you frame things, how you deal with some of those, like, again, pre-existing like nervous system trauma stress components. The amplify bucket of things goes a bit under rewire too. It's not just the pain response and the amplification that you're trying to deal with, but the other aspects that complicate our experience with pain with the rewire bucket. But that's the last piece, right? If you can't eliminate all the drivers or get rid of all the causes, well, how are you going to change the way that you're dealing with that signal that's still coming in at too high of a level?
Yeah.
So those
it's
are the
disproportionate
4 steps.
Signal.
That's the bucket where, from an outsourcing perspective, movement professional, physical therapist, even a fitness coach, if there's someone who works with, right, that's basically what I do, but these type of special populations, that's where that can be helpful as well.
And we're talking there about taking the danger signal that pain is.
Dims and sims.
And taking out dims and sims, taking out the danger from the signal. And I think that the pain condition most necessary and probably most effective in many ways that you use to rewire is around complex regional pain syndrome. Complex regional pain syndrome is a disproportionate signal that's being driven at a dorsal root ganglion level, and the signal is just screaming at you. And how do you, if you can't turn it off,
right,
you've got to rewire around it. And that is where, you're using your neuroplasticity and a bunch of other techniques to rewire to downregulate the pain.
And it takes time, but you can. And that's where, if you're intentional about it, right, and you construct like a whole life where that's how you're approaching things, you absolutely can make big dents in higher pain. It's just challenging.
If we're going to summarize it, I say, so if we bring it all together, what do you want to do? So number one, you want to avoid phrases that can be heard as it's in your head. And that includes, incorporating words like brain, misinterpretation, think, decide.
Brain generated.
And heaven forbid you actually just tell the patient it's in their head, which, let's be honest, takes place.
Pain to the brain rather than the body.
Yeah. Don't be perceived as, or don't be heard as lying to the patient. If there's something going on in a scan, explain it.
Right.
Patients don't buy it. That's the way it is. Patients just don't buy it.
And I think if the position was switched, you wouldn't buy it. Like, if you put yourself in that person's shoes, you wouldn't buy it. Right. So it's like, patients aren't dumb. Yes, they have a different level of education than, of course, what you do in this specific thing, but we're all human. Treat them, as such, I think. Don't
give implausible explanations. The sky is blue, yes, because our brains choose it to be blue. But honestly, it is such a difficult thing to believe from a patient perspective that, you lose the patient immediately and it becomes an implausible explanation.
Yeah.
Don't set unreasonable expectations.
Yep.
And,
this is where the impact of certain therapies comes in, right? If you
Yeah,
send someone to a pain program, what are you impacting with that?
Yes. So pain programs, they don't decrease pain. Pain programs
Improve attitudes, right?
Improve attitudes. They improve coping skills. You get, if you look at the data, you get transient improvements in anxiety and depression that last for approximately 3 months. But they generally don't decrease pain. They improve coping strategies.
Your ability to deal with it.
Which is really important.
Yeah.
But
expectation management.
But expectations. So when I send patients off to a pain program, I start with it should be called a coping program, not a pain program.
Right.
This podcast has been directed at clinicians mainly. So really, to wrap this up, the last piece that's important is that if you're a patient on the other side of this and you're given an explanation of pain that you hear as it's in your head, the reply to that is, do you want to swap? Because what that does is that forces the clinician, even if it is for a split second, to step into your shoes and think about it from your side.
Right. And why would the patient?
Why would this
create this whole?
Why would you make this pain up so that you lose your job, lose your relationships, lose the ability to do everything that you want to be able to do, et cetera, et cetera. Like, why would you make a decision to lose all of that? And very quickly what happens is the clinician steps back and goes, yeah, no.
That doesn't make as much sense as the alternative.
And so the pain's not in your head. It's a disproportionate signal. You do not decide to
how you
experience
interpret
pain.
It. Right.
But we can use the way we think to rewire around it.
Yeah. And that's what we want to take out of this episode is the useful techniques and, like we said, reduce the harm in how they get communicated and whom they're applied to, essentially.
And just to finish up, look, we know that for chronic pain patients, there's a 25% risk of suicidal ideation in the last 2 weeks. If you are feeling that way, if you don't feel safe, please, in Australia, you can reach out to Lifeline. So their number is 131114. And in the US, Jazz?
US, you can reach out to 988, or you can also reach out to 741-741. And that's the WhatsApp number, right, Dan, that you can also send home to?
And they will you can go to their website and they will also pull up a chat immediately or send a text message out of their site. So it's a great little service. So please use them if you need.
Yeah.
I suppose finally, it's 2 finalies. We have put together a survey. So one of the things we recognise out of this is that there hasn't been any
little research.
There's little research done on, the harm of pain education in this setting. So there's research on the harm of, psychotherapy, and there's research on the harm of hopelessness. So what we've actually done is we've put together a questionnaire. If you'd like to fill it out, it basically asks, have you been told that your pain's in your head, and what are the consequences of those? And for some people, it might have been quite positive that you're able to work through things in a different way, think about things in a different fashion,
analogy.
And is able to, get around your pain. But for others, obviously there's probably negative downsides. And so we'd like to be able to understand what they are and then be able to share it in a broader fashion.
In a more significant way. Yeah.
And in a scientific fashion as well, which will hopefully spark some behavior change on, the clinician side.
Right. Changing of phrases that lead to harm. All right. Thanks a lot, guys, for listening. We appreciate it. And we will see you next time on It's Not in Your Head. Bye.
Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not a consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.